Hello, everyone. I'm Ulrich Sidney, the president of the Association of Future African Neurosurgeons. Today, we have another session of our lecture series on neurosurgical emergencies. We have two lectures today um, by two wonderful and very active members. One is Zolo Yvan, the other is Dr. Natalie Gomsi. Before we start, we're going to present ourselves. I'm currently a research associate program in global surgery and social change at Harvard Medical School. So, Natalie, you present yourself first, and then Zolo can start.
Hello everyone, I'm Natalie Gomsi. I'm a medical doctor, a PG1, year one neurosurgery in Ivory Coast. Nice to meet all of you. I think I know everybody, so nice.
Yeah, great. Okay, Zolo, you can present yourself and run with it.
Hello everyone, I am Zolo Yvan. I am a CTA medical student from Cameroon. I'm a member of the Association of Future African Neurosurgeons, and I am happy to be here with you. I don't know if there's somebody else who needs to present himself.
No, you can go ahead.
All right. So I will share my screen. Okay. Can everyone see?
Yes.
Good.
Yes, okay.
Good. So today we are going to be speaking about cerebral venous thrombosis, and it will be done by me, Zolo. Some small. Okay, good. So you're going to follow this plan. You're going to have an introduction, speak about the epidemiology, then have some anatomy review of the venous drainage of the brain and the central nervous system. Then you're going to speak about the pathology of cerebral venous thrombosis. You're going to speak about how to make the diagnosis and the management. Then you're going to see the prognosis of cerebral venous thrombosis, and you're going to give a brief summary. And then I'll show you my references. So cerebral venous thrombosis, also called cerebral venous sinus thrombosis, is the presence of a blood clot in the dural venous sinus, which drain blood from the brain. In 1825, Ripes described the first case of cerebral venous thrombosis, which was later confirmed by autopsy in a 45-year-old male with severe headache, seizure, delirium, and thrombosis involving the superior sagittal and the lateral sinuses. In 1828, Abercrombie reported the first postpartum CVT in a 24-year-old woman who developed headache and seizures 2 weeks after an unremarkable delivery. Autopsy revealed thrombosis of the superior sagittal sinus and the cortical veins. In 1968, Kraibu, sorry for the pronunciation, conducted a retrospective study of 92 patients with CVT diagnosed by angiography, surgery, or autopsy. In that study, 37 of these cases, that makes 40%, were associated with infection, and 17 of the remaining were non-infectious cases which were associated with a pregnancy, abortion, or the perinatal period. In these patients, headache, varying degrees of paresis, and the seizures were the most common manifestations. Headache was often unilateral, and the seizures were usually furious. Among these 92 patients, 35 died. In 1985, Browser et al. Found that the incidence of infectious CVT was significantly reduced by the use of antibiotics, whereas the incidence of CVT associated with other factors, including trauma, Behçet's disease, and the perinatal period, the use of oral contraceptive, neoplasms, nephrotic syndrome, coagulation factor, and other abnormalities was higher. With the advent of new diagnostic techniques such as CT venography and MRI angiography, it has become easier to achieve an early diagnosis of CVT. Currently, the largest study to explore CVT are an Italian multi-center study of 760 CVT patients and a multi-center, multi-country study of 624 patients. which is also the study is called the International Study on the Cerebral Vein and Dural Sinus Thrombosis. So now you're going to speak about the epidemiology. So as epidemiology, the incidence of CVT is 13.2 cases per million per year, and CVT often occurs in young people and women of childbearing age. Affected children are usually newborns. The incidence of CVT in neonates and children is 0.67 cases per 100,000 children per year, and the incidence of perinatal CVT is 11.6 cases per 100,000 deliveries in pregnant women. More females are affected with CVT than males, with the use of oral contraceptive being incriminated for this disparity. The more frequent the risk factors or risk factors associated with CVT, the most frequent risk factors associated with CVT are genetic prothrombotic conditions, antiphospholipid syndrome, and other acquired prothrombotic diseases, including cancer, puerperium, and pregnancy, smoking, infections, and trauma. In the majority of patients, multiple venous sinuses are involved. The superior sagittal sinus, lateral sinus, and the sigmoid sinus are the most frequently involved. A multicenter, multi-country study reported that approximately 10.9% of patients with CVT exhibit deep venous system involvement. 17.1% exhibit cortical vein involvement, and 11.9% exhibit jugular vein involvement. The cerebellum and the cerebellum and the cavernous sinus were involved in only 0.3 and 1.3% of patients, respectively. CVT is less frequent than ischemic stroke, and also than intracerebral or subarachnoid hemorrhage. CVT is also more frequent in low middle income countries, particularly those with high pregnancy rate. CVT have a more varied clinical presentation than other stroke types, and hence they are more difficult to recognize. As anatomy, the veins of the central nervous system drain deoxygenated blood from the cerebellum, the cerebellum, the brainstem, and the spinal cord. After emptying into the dural venous sinuses, most cerebral venous blood flows into the internal jugular veins before it is returned to the heart. Veins draining the brain parenchyma may be divided into superficial and deep veins. The superficial veins primarily drain the cerebral cortex, whereas the deep veins drain the deep structures within the hemispheres. These veins do not typically follow the arterial supply, and there is significant variation in the anatomy between different subjects. Another notable feature of cerebral veins is that they lack muscular walls and valves. The cerebral veins empty into the dural venous sinuses situated within the subarachnoid space. The superficial system drains into the superior sagittal sinus, while the deep system drains into the transverse, the straight, and the sigmoid sinus. The superficial venous sinus comprises the sagittal sinuses, the cortical veins, the cortical venous system, which is further divided into the superior, middle, and inferior groups. There are several important superficial cerebral veins: the superior anastomotic vein of Troller, the superficial middle cerebral vein, also called the Sylvian vein, and the inferior anastomotic vein of Labe. So on this diagram, you can see the dural venous sinuses. So here we have the superior cerebral veins, and here we have connecting this sinus and the Sylvian vein. We have the superior anastomotic vein of Troller, and now connecting the Sylvian vein and the rest of the sinuses below, is the inferior anastomotic vein of Labe. So this is a brief description of what was just explained. And you see all over they drain into the internal jugular vein. So here, inferior anastomotic vein of Labe connects the superficial middle cerebral vein with the transverse sinuses, as I just showed. The location of this vein is extremely variable, making it vulnerable to injury during craniotomy procedures. superior anastomotic vein of Troller connects the superior sagittal sinus with the superficial middle cerebral vein, which is also called the Sylvian vein. It is usually the smallest of the three superficial veins. Superficial middle cerebral vein usually courses along the Sylvian fissure and picking up veins from the surrounding operculum as it runs anteriorly. It then drains into the cavernous sinus after curving around the anterior temporal lobe. So here again we have the superior sagittal sinus. Here connecting the superior sagittal sinus and the superficial middle cerebral artery or Sylvian vein. Superficial middle cerebral vein or the Sylvian vein is the superior anastomotic vein of Troller, and connecting this Sylvian vein to the transverse sinus is the inferior anastomotic vein of Labe. So it's just a repetition of the diagram we just saw. But here they actually show us the flow of the blood. So you see blood leaves from here from the superior cerebral veins, gets into the superior sagittal sinus, and you see the flow. So the deep cerebral venous drainage system comprises the sinuses, which are the transverse, the straight, and the sigmoid. And the deep cerebral veins are the subependymal and the medullary vein. This system drains the thalamus, hypothalamus, internal capsule, septum pellucidum, choroid plexus, corpus striatum, and the white matter. Internal cerebral veins, which is a pair of veins, originate at the foramen of Monro and run posteriorly within the roof of the third ventricle. These two internal cerebral veins eventually anastomose to form the great vein of Galen. The two basal veins are closely related to the midbrain structures and drain into the great vein of Galen, which is also called the great cerebral vein. And the origin of these veins lies close to the anterior perforated substances. So here we see the internal cerebral veins. You see they come and they unite to form, and to empty into the great cerebral vein or the great vein of Galen. And here also you see the basal vein. You see they come and they also empty into the great cerebral vein. So that's what we are just explaining in the notes. So here also you still have the diagram showing what we have already explained, is just to better see. So the striate veins drain the caudate nucleus, the thalamus, the corpus striatum, and the internal capsules, returning blood to the internal cerebral and the basal vein. The superior striate veins empty into the internal cerebral veins, while the inferior striate veins empty into the basal veins. The great vein of Galen passes beneath the corpus callosum and anastomosis with the straight sinus, as well as the internal cerebral and basal veins. It receives blood from the corpus callosum itself as well as the occipital lobes. So here we see the great cerebral vein, and we see the straight sinus. You see a confluence of sinuses, a transverse sinus, and you see you come here and the blood will flow passing through the sigmoid sinus. So the superior and inferior cerebellar veins drain this region. The former empties into the transverse straight and the superior petrosal sinuses, and the latter drains into the sigmoid, inferior petrosal, occipital, and the straight sinuses. The oxygenated blood is drained from the midbrain region as it empties into the great cerebral and the basal veins. Inferiorly, veins drain blood from the pons and the medulla into the superior and inferior petrosal sinuses, as well as the transverse and occipital sinuses. So the dual venous sinus layers lie between the outer or the periosteal and the inner or the meningeal layer of the dura mater. Cerebral veins discussed above drain blood into the sinuses and follow a course through the dural venous sinus system, eventually meeting the internal jugular veins. There are no valves within the sinuses, as well as, as already explained before. The falx cerebri contains the superior and the inferior sagittal sinuses, as well as the straight sinuses. The sinuses anastomose at the confluence of sinuses and the anatomical landmark of the internal occipital protuberance. So this is what we're explaining here. You see, this is the periosteum, the outer table. This is the inner table, and you see, this is the sinus here. So the inferior sagittal sinus meets the great cerebral vein before continuing as the straight sinus. The transverse sinus emerge from the confluence and go on to form the sigmoid sinus, which drain into the internal jugular vein as they leave the cranium via the jugular foraminum. The cavernous sinus is located anteriorly and receives blood from the ophthalmic veins before emptying into the superior and the inferior petrosal sinuses, and subsequently the inner jugular veins. So here is again a diagram to summarize all what we just explained. This one too, I've actually explained all of it, but just to better see what we were explaining. So let us now speak about the pathology of cerebral venous thrombosis. So approximately 80% of CVT cases have an acute to subacute onset. The median time from onset to diagnosis is approximately 7 days. Approximately 20% of patients had a chronic onset, and the chronic CVT patients require extra attention to avoid a misdiagnosis because of the presentation associated with its traditional onset. Numerous causes have been provided for the development of cerebral venous thrombosis, which can be broadly divided into categories. So we have infectious causes and non-infectious causes. Infectious causes mainly include migratory involvement of the cavernous sinus from Staphylococcus, infection of the face and the paranasal sinuses, while the non-infectious causes are in which the systemic conditions such as connective tissue diseases, other granulomatous or inflammatory disorders, and malignancies are the most common. Cerebral venous thrombosis refers to complete or partial occlusion of the main sinus or sinuses or the feeding cortical veins, leading to effects of vascular congestion and the focal or generalized neurological deficits. The local effects depend on the site of occlusion, and a sinus block leads to intracranial hypertension, whereas the deep cortical occlusion will cause localized edema, venous infarction, and petechial hemorrhages. It's very important to know this difference because it will help you in making the diagnosis and imagining where or guessing where the lesion is found. The later can merge and become large hematomas which have a characteristic appearance and on computed tomography. Okay, since in majority of instances the deep cortical veins get involved due to a sinus block, these two scenarios get overlapped and we see a mixed picture. Isolated instances of cortical venous thrombosis without sinus involvement are rare. Formation of thrombi is in venous channels draining the brain is a consequence of the characteristic risk factor under the heading of Vicus triad, which includes local trauma to vessel wall, stasis, and a hypercoagulability state. The latter being the most important factor in development of cerebral venous thrombosis, unlike the other venous thrombosis that we found in the body. Several morphological factors leading to development of thrombi in venous channels have been noted. The striking involvement of superior sagittal sinus in majority of the cases can be attributed to the fact that the superficial cortical vein draining into it are doing so against the blood flow in the sinuses. This, along with the presence of a fibrous septate present at the inferior angle of the sinus, causes turbulence, hence rendering it more susceptible to thrombosis. A thrombosed sagittal sinus leads to a compression of the arachnoid villi, which drains CSF from the ventricles, leading to raised intracranial pressure and papilledema. Very important to understand this because it's going to dictate the presentation of the patient. So, however, hydrocephalus does not develop as the ventricular communication with the subarachnoid space remains pattern. About 1/5 of patients with sinus thrombosis have intracranial hypertension only, without signs of cortical vein thrombosis. Vasogenic edema developing due to a disruption of blood-brain barrier and engorgement of the brain interstitium with blood, and cytotoxic edema resulting from localized ischemia and damage to intracellular ion channels, eventually leading to neuronal swelling, is a characteristic of cerebral venous involvement. Magnetic resonance imaging has shown that both cytotoxic and vasogenic edema occur in cerebral venous thrombosis. The outcome of such a venous drainage compromise can be divided into two. So we have the disruption of blood-brain, and the blood-CSF barrier can lead to hemorrhage and development of hematomas. And secondly, the venous infarction localized to the area where integrity of the secretion is lost. So this outcome will decide the clinical picture that will follow. So hypercoagulable state has been attributed as one of the major risk factors in the development of CVT. Mutation in genes encoding for coagulation factors increase basal production of these factors in certain physiological and pathological states, and certain malignancies and autoimmune disorders, leading to an imbalance between prothrombic and antithrombotic factors. The association of a pregnancy and puerperium with cerebral venous thrombosis can be explained by the fact that there is a state of compensated accelerated intravascular coagulation as is necessary for maintenance of the uterine placental interface and preparation for the hemostatic challenges of delivery. This is achieved by a physiological increase in production of coagulation factors that induce a prothrombotic state. So, whereas arterial cerebral ischemia is usually a monophasic abrupt thrombotic process, and there is only a small penumbra, cerebral venous thrombosis is a continuing process of disequilibrium between prothrombotic and thrombolytic mechanisms. Large areas of the brain are only functionally or metabolically disrupted, but not irreversibly damaged. So intracranial bleeding in SVT is a consequence of increased venous and capillary pressure, and thus occur more frequently than in arterial thrombotic disease, in which capillary pressure is reduced by the thrombosis and bleeding occurs during reperfusion of tissue damaged by ischemia. This explains the greater incidence of hemorrhagic infarct in venous occlusion compared to arterial ones. Pseudotumor cerebri, which is a syndrome many patients of cerebral venous thrombosis present with, develop as a result of increased pressure in the affected dural sinuses. In fact, patients with a pseudotumor cerebri syndrome should undergo angiography of brain MRI before being labeled idiopathic. Growth of the thrombus and the good collateralization of the venous system probably explain the usually gradual onset of symptoms, frequently over weeks and months. In contrast to arterial thrombi, spontaneous resolution of venous thrombi does occur. This explains the large number of patients with complete reversibility of their neurological deficit, as there is a large area of only transiently and reversibly disrupted cerebral tissue. Mechanisms underlying cerebral venous thrombosis and deep venous thrombosis of other areas are probably different. First, cerebral veins and sinuses have a continuous blood flow and no valves, whereas venous flow in the limbs is not continuous but requires the presence of valve and the activity of muscles. Secondly, the factors that appear to precipitate deep venous thrombosis, including immobilization, do not increase the risk of cerebral venous thrombosis. Very important to know. Moreover, there is a stronger association of deep venous thrombosis with cancers than cerebral venous thrombosis. So, How do we make a diagnosis of cerebral venous thrombosis? The clinical presentation of cerebral venous thrombosis is highly variable. The mode of onset of cerebral venous thrombosis can be acute, but is rarely stroke-like. More often, onset is subacute and less frequently chronic. Symptoms and signs of CVT can be grouped in presenting syndromes, the most frequent ones being isolated intracranial hypertension syndrome, focal syndrome, and encephalopathy. Less frequent presentation syndromes are cavernous sinus syndromes or syndromes of multiple paralysis of the lower cranial nerves, which are cranial nerve 7, called Sicard syndrome. The syndrome of isolated intracranial hypertension features headache with or without vomiting, papilledema, and visual obscurations, decreased visual acuity or enlargement of the blind spot or concentric restriction of the peripheral visual fields, and less often tinnitus and the cranial nerve 6 palsy. Cranial nerve 6 palsy. Papilledema and visual loss are more frequent in cases with chronic onset who present late. Headache is the most frequent symptom of CVT and usually the initial one. A reasonable proportion of CVT patients, in particular those who come early to medical attention, complain only of headache, which is mainly isolated headache. As headache in general, headache associated with CVT is more frequent in women and in younger patients. The most frequent type of headache is the intracranial hypertension type, a severe generalized headache of progressive onset, persistent worsening with straining, visceral maneuvers, and when the patient is lying down. So in a few cases of cerebral venous thrombosis, headache as the future of migraine with aura or thunderclap headache. Is everyone getting me?
Yeah, we are getting you.
Okay. Good. So a few cases presenting as non-aneurysmal subarachnoid hemorrhage, either generalized or localized to a single or few cortical sulci of the hemispheric convexity, have been reported. While CVT patients with generalized subarachnoid hemorrhage present in general with sudden explosive headache and displaced stiff neck, those with convexity subarachnoid hemorrhage have a more complex symptomatology. Using a headache questionnaire in 25 CVT patients, Sparacco et al. Described headache as typically severe, throbbing with sudden onset and non-remitting. So other patients present as a focal syndrome, that is a focal deficit such as paresis or aphasia, seizure, or both. Hemianopia and other sectorial visual field defects are uncommon, as well as cerebellar signs. Seizures can be focal or reported as generalized from onset and may evolve to status epilepticus. Seizures are more frequent in patients with supratentorial lesions, in particular if hemorrhagic, and in those with a motor and sensory deficit and superior sagittal sinus or cortical vein thrombosis. CVT should always be considered in the differential etiology diagnosis of a new onset seizure in the young and middle-aged adult. So severe presentation syndrome of CVT is encephalopathy. These patients have decreased consciousness, mental status disturbances, including delirium, apathy, or dysexecutive syndrome, bilateral or multifocal signs, and or seizures. Comatose patients usually have multiple sinus occlusion. The clinical presentation of CVT varies according to the age of the patient, the time of diagnosis, and the presence of the parenchymal lesions and the venous topography of the thrombosis. Encephalopathy is more frequent in elderly patients, while headache is less frequent in this age group. Isolated intracranial hypertension and papilledema are more frequent in patients with a late chronic presentation. There is a gradient of increasing clinical severity from patients without brain lesions to patients with non-hemorrhagic lesions and hemorrhagic lesions. Motor deficits, seizures, mental status disorder, and decreased consciousness are more frequent in patients with brain lesions, while isolated intracranial hypertension syndrome is rarer. In cavernous sinus thrombosis, there is usually headache, orbital pain, chemosis, proptosis, ptosis, diplopia, and oculomotor palsies. Typically, cortical vein thrombosis produces motor and or sensory deficit and seizures. You understand why? Patients with isolated thrombosis of the lateral sinuses often present as isolated intracranial hypertension, but aphasia is frequent in left transverse sinus occlusion. Also understand why? If the deep cerebral venous system is thrombosed, the clinical picture is often severe with coma, mental deficits, and paresis. Occlusion of the cerebral veins is uncommon and has usually a subacute presentation. The majority of these patients have an intracranial hypertension syndrome, but less than half have a cerebellar syndrome. So the different modalities that we can use to make the diagnosis, we have been confirmatory of, we have magnetic resonance imaging with MRI venography, we have computerized tomography with CT venography, and we have angiography. So these are the modalities that we can use to make a diagnosis apart from the clinical presentation of the patient. So let us look at magnetic resonance imaging. This is a combination, here is a combination, in combination with the magnetic resonance venography, has become a non-invasive imaging technique of choice. The diagnosis requires visualization of thrombus within the vessel in a combination with absent flow of MRI venography. A panel of several MRI techniques is in addition to MRI venography. Rather, an isolated technique can significantly enhance the accuracy of the diagnosis. Administration of contrast material and application of specific MRI sequences and venographic techniques are often required for confident diagnosis. So, MRI allows visualization of thrombus within the sinus or the veins. The MRI signal can vary on different sequences according to the age of the thrombus. In the first 5 days, the signal is isodense. You should remember this. So in the first 5 days, the signal is isodense on T1 weight imaging and hypodense on T2 weight images. After this time, there is an increased signal on both T1 and T2 weight images. So first 5 days, signal isodense in T1 and the hypodense in T2. And then after, the signal on both images is increased. So after the first month, there is a variable pattern of signal which may more frequently become isodense or hyperdense on T2 weight images and hypodense on or isodense on T1. Gradient echo T2 and susceptibility weight imaging, that is SWI, sequences improve the diagnosis of CVT, enabling the identification of intraluminal thrombosis as a hypodense area. These sequences are particularly useful in the acute stage of dural sinus thrombosis and in the diagnosis of cortical vein thrombosis. The use of susceptibility weight imaging or SYI may be outstanding in the diagnosis of isolated cortical vein thrombosis because this sequence may demonstrate a thrombus in a cortical vein. A chronically thrombosed sinus may still demonstrate low signal on these sequences. So here we have a magnetic resonance imaging in combination with magnetic resonance venography confirmed with sigmoid sinus occlusion in patients with acute headache. So on A, we have enhanced MRI T1 weight image, which shows an isodense signal inside a sigmoid sinus corresponding to an opacified thrombus. And then on B, we have MRI venography typically demonstrate the absence of flow in the corresponding part of the thrombosed sinus. So here we have the absence of flow. Here we see how there's blood here, but here there's nothing. If you try to compare it to, this is sigmoid sinus. If you look here, you see that there is no flow here. So it's dark, completely dark. And then on the image C, 3 months later, an almost complete recanalization of the sigmoid sinus is observed. So you see here, if you compare this one and this one, you see that there's no flow here, but here if you see, it is totally dark. Okay. So here we have a non-enhanced T1 weight and T1 weight. Okay, on A we have an MR venography. So if you see here, if you try to compare, for example, A and the C, you see that here it is dark where the arrow is. But if you see here, there's, and they say that image C, there has been some partial recanalization. So you see that here blood is already passing here, but here there was no, there was no blood here. So can we see that? Okay, good. And the other images. Also here we have the superior sagittal sinus. If you look here, there's no signal here, but here you see a signal already present. If you compare the two images, here there's no signal, and here there's a signal already. So, and here is a flare magnetic resonance image showing high intensity venous infarct. So if you see here, there's a lesion here and here. So B is a T2 with MRI showing a linear hypodense signal in a cortical thrombosed vein. That's it. So MR venography. Several methods can assess venous or dural sinus flow on enhanced 2D time of flight, which is TOF, MR venography, 3D time of flight, MR venography, contrast enhancement, MR venography, and phase contrast MR venography. All these techniques can be used. So the 2D TOF MR venography is the most commonly used method for the diagnosis of CVT, which typically demonstrates the absence of flow in a thrombosed vessel. Contrast enhanced MR venography is more sensitive than TOF MR venography. MR venography has several limitations and potential pitfalls in the diagnosis of cortical vein thrombosis, of partial sinus occlusion, and in distinction between hypoplasia and thrombosis. Reliance on other MR sequences such as T2 gradient echo or SYI may surpass the limitation of cortical vein thrombosis diagnosis. The use of contrast may help in other situations. For example, a thrombosed hypoplastic sinus will have marked enhanced sinus signal and no flow on 2D TOF venography. A non-thrombosed hypoplastic sinus will not present abnormal low signal in T2 gradient echo or SYI. So on the CT and CT venography, there are patients with a contraindication to perform MRI, and in some hospitals, the access to MRI is limited in our context, for example. Therefore, computed tomography associated with CT venography can be an alternative technique to diagnose CVT. In the emergency setting, CT is often performed and is useful to rule out acute or subacute cerebral disorders that may mimic CVT, such as tumor, subdural hematoma, and abscess. CT is normal in up to 30% of cases of CVT, and most often the findings are non-specific. So classical direct signs of CVT are present in about 1/3 of cases and refers to the visualization of thrombosis, the cord sign, which is thrombosed cortical or deep vein, the dense triangle sign, which is visualization of the clot inside the sinus, and the empty delta sign, which is visible after injection of contrast agent as contrast between the non-opacified thrombus inside the sinus and the collateral veins of the sinuses. So this statement help us understand why MRI is a imaging modality of choice compared to CT. But if you don't have access to MRI, at least we can use a CT to help us make our diagnosis by looking at all these signs that have been mentioned. So a recent study reported interesting results on the diagnosis accuracy of non-enhanced CT, suggesting that measurement of the venous sinus attenuation can increase the sensitivity of this examination in the diagnosis of acute CVT, Parenchymal anomalies occur in 60 to 80% of cases, and some patterns are highly evocative of CVT, such as multiple bilateral lesions, bilateral thalamic edema, temporo-occipital lesions, small juxtacortical hemorrhages, or convexity subarachnoid hemorrhages. CT venography readily available after brain CT can confirm the diagnosis of CVT, showing filling defects in the dural sinus and cortical veins, sinus wall enhancement, and increased collateral venous drainage. So CT or CT venography has some advantages over MRI, which is we have a rapid image acquisition, of course. We have fewer motion artifacts. We have no contraindication to patients with ferromagnetic devices, and easier to be used in patients with claustrophobia. Additionally, CT venography may be superior in imaging sinuses or cerebral veins with low flow. So some limitations of CT and CT venography are difficult visualization of the skull-based structures in three-dimensional display, low resolution for small parenchymal lesions, poor detection of cortical and deep venous thrombosis, the risk of contrast reactions, radiation exposure, and risk of iodinated contrast neuropathy, which may limit its use in pregnant women, children, and patients with renal failure. So yeah, we have on A, we have so this direct signs, dural sinus thrombosis in a non-contrast computed tomography head scan. So on A, we have spontaneous hyperdensity of the right transverse sinus. Yeah. And on image B, we have the straight sinus. So if you see here, so this is for A and this is for B, the straight sinus. And on C, we have this the sagittal sinus, which is a hyperdense vision. So intra-arterial angiography, which is one of the modalities that we spoke about as to use in diagnosis, has a spatial resolution superior to CT or MR venography, but is currently rarely performed. It is reserved to cases with inclusive or contraindicatory findings in other imaging modalities to exclude a dural arteriovenous fistula or when therapeutic intervention is planned. Typical signs of CVT or CVT on angiography are partial or complete lack of filling of veins or sinuses, delayed emptying, dilated collaterals, and the sudden dropping of cortical veins surrounded by dilated and tortuous collateral, which is also the corkscrew veins. Anatomic variations may limit the interpretation of angiography, such as hypoplasia of the anterior part of the superior sagittal sinus, duplication of the superior sagittal sinus, and the hypoplasia or aplasia of the transverse sinus. So, laboratory tests that can be, beside the imaging, there is no confirmatory laboratory test that can confidently rule out acute CVT. So elevated D-dimers support the diagnosis of CVT. It supports, we don't say that you cannot say that it's actually like help us make the diagnosis, but it will support the CVT if you have it with other findings, clinical findings, and some radiologic findings. A systematic review collected for 14 published studies that has accessed the value of D-dimers in the diagnosis of 1,134 CVT patients. D-dimer accuracy was good, with a sensitivity of 94% and specificity of 90%. However, false negative D-dimer occurred in patients with isolated headache, longer duration of symptoms, and limited sinus involvement. In contrast, a normal D-dimer level cannot rule out the diagnosis, and measurement of plasma D-dimer level is not a good screening test in patients with suspected CVT. So as management, let us now have a word about the management of CVT. This management is focused on timely diagnosis and treatment. Treatment is predominantly anticoagulation to prevent propagation of the thrombus and reduce the likelihood of complications such as pulmonary embolism. Both the American Heart Association and the American Stroke Association and European Federation of Neurological Societies guidelines recommend that patients should be anticoagulated even in the presence of hemorrhage. A bit controversial. So the evidence for this is limited to 2 small randomized controlled trials of unfractionated heparin and the low molecular weight heparin. Both randomized controlled trials showed better clinical outcomes and reduced mortality rates in patients receiving anticoagulation compared with controls without increased incidence of intracranial hemorrhage. A meta-analysis of both randomized controlled trials showed a 13% of absolute reduction in mortality or dependency in anticoagulated patients, although this was not statistically significant. There is still debate around the most appropriate method of anticoagulation, and in systemic venous thrombosis events, studies suggest that low molecular weight heparin is superior to unfractionated heparin at prevention and reducing thrombosis size, but it is unclear whether this can be applied to cerebral venous thrombosis. However, a recent single-center randomized control trial demonstrated a significantly lower mortality rate in patients receiving low molecular weight heparin compared to unfractionated heparin. Currently, the recommendation is immediate commencement of therapeutic low molecular weight heparin or unfractionated heparin. That's the take-home message here. Currently, they recommend, yes, in addition to anticoagulation, underlying etiological factors should be investigated and managed. Very important. Should manage the underlying cause. Immediately reversible risk factors should be addressed, such as stopping the pro-thrombotic drugs, rehydration, and antibiotics. It might be appropriate to screen for prothrombotic and or genetic factors, but not in the acute phase. And it is usually helpful to seek guidance from a hematologist. Important. If an infective or inflammatory cause is suspected, particularly in the head and the neck, lumbar puncture should be considered if there is no contraindication such as mass lesion. This should ideally be performed immediately before anticoagulation. In some cases, patients might not respond to treatment with continued deterioration, and 9 to 13% of patients with CVT have a poor outcome despite anticoagulation. Transtentorial herniation because of raised intracranial pressure is the most common cause of death. Most patients will have symptoms and signs of raised intracranial pressure, and it is vital to carry out fundoscopy and monitor for progressive visual loss. Treatment with acetazolamide, although of limited evidence base, can be considered in raised intracranial pressure without immediate risk of uncal herniation. Lumbar puncture can rarely be performed during the emergent phase after anticoagulation. However, performing a lumbar puncture necessitates cessation of anticoagulation, and although time of anticoagulation can be mitigated by using unfractionated heparin, there remains a risk of further thrombosis. Therefore, lumbar puncture should be reserved for suspected severe raised intracranial pressure, including with threat to vision, when other definitive neurosurgical measures might also need to be considered. In anticoagulation, if anticoagulation is contraindicated or in cases of severe CVT, not responding to anticoagulations, endovascular thrombolysis or mechanical thrombectomy might be an option, although evidence to support this approach is currently lacking. Steroids are not recommended. Steroids are not recommended and are linked to a poorer prognosis in CVT, even with the presence of parenchymal lesions, unless indicated by an underlying condition such as meningitis or malignancy. Anti-epileptic drugs should not be given routinely as prophylaxis, but should be initiated quickly if a seizure occurs. Patients with rapid neurological deterioration because of impending herniation can benefit from decompression with craniectomy. Following the immediate management of CVT, long-term vitamin K antagonists such as warfarin with a target international normalization ratio INR of 2 to 3 should be used. The duration of anticoagulation depends on etiology. So the guidelines recommend anticoagulation for 3 to 6 months in provoked CVT. 6 to 12 months in unprovoked CVT, and potentially lifelong in recurrent CVT. VTE following CVT or CVT associated with severe thrombophilias. More recently, the American College of Chest Physicians guidelines suggest that for provoked VTE, anticoagulation should continue for 3 months, this was an aside, and for unprovoked, it should be reviewed after 3 months and thereafter annually for bleeding risk. It is not clear whether this can be applied to CVT, which to some extent has a different risk factor profile. So, no correlation has been found between recanalization and clinical outcome. Direct oral anticoagulation, anticoagulants is a potential treatment option in patients for whom warfarin is not suitable but should not be recommended as a first-line therapy. So, about the prognosis, cerebral venous thrombosis usually has a good prognosis but can result in death or permanent disability. Clinical cause is unpredictably in the first days after diagnosis. About 1/4 of CVT patients experience a neurological worsening presenting depressed consciousness, mental status disorder, new seizure worsening, or a new focal deficit, increase in headache intensity or visual loss. Patients with depressed consciousness on admission are more likely to deteriorate. Seizures are more likely to recur in those with seizures at onset and to occur de novo in patients with parenchymal lesions. About 1/3 of patients with neurological deterioration will have new parenchymal lesions in neuroimaging if neuroimaging is repeated. Approximately 5% of patients die in the acute phase of the disorder at the side. The main cause of death with acute CVT is transtentorial herniation, secondary to a large hemorrhagic lesion, followed by herniation due to multiple lesions or to diffuse brain edema. Status epilepticus, medical complication, and pulmonary embolism are among the other causes of early death. Deaths after the acute phase are mainly due to underlying conditions, in particular malignancies, or to fatal bleeding related to prolonged anticoagulant therapy. Patients presenting with the isolated intracranial hypertension syndrome usually have excellent outcome, more than 90% achieving a complete recovery. Prognosis is less favorable in patients at both extremities of age, and patients who survive the acute phase of CVT are at risk for complications such as further venous thrombotic events, seizures, and headaches. Severe visual loss due to intracranial hypertension is very rare. Despite apparently good recovery, many patients report residual symptoms. Psychological and cognitive complaints are common among CVT survivors. About half of the survivors of CVT feel depressed or anxious and demonstrate minor cognitive or language deficit, and a substantial proportion remain unable to return to work life. So I think psychological consultation is important. So in summary, the pathophysiology of cerebral venous thrombosis depends on two interconnected events: local signs due to venous infarct and isolated intracranial hypertension being one of them. CVT is more frequent in infants and children, young adults, and females. Their most frequent presentations are isolated headache, intracranial hypertension syndrome, seizure, or a lobar syndrome, and encephalopathy. It has various risk factors and predisposing conditions that we have seen. The prognosis of CVT is in general favorable. Treatment with the acute phase includes management of the associated conditions, anticoagulation with either low molecular weight or unfractionated heparin, treatment of intracranial hypertension, prevention of recurrent seizures, headache relief, and decompressive surgery in some cases. There are several ongoing multicenter registries and trials which will improve evidence-based and patient-centered management of CVT in the near future. Here are my references, and on this image we always keep on speaking about universal health coverage. So both of them have some sort of health system, but only one is really protected. So we should do everything for all our patients to have access to a good health system. So thank you very much for your attention, and